Hi, my name is Katie Lee Huang, and welcome back to the GI Pathology section. So now that we've given you some basis for how the GI system works normally, let's now launch into all the different ways it can become diseased. Let's first start at the mouth. We mentioned the components of saliva and the 3 paired salivary glands in the physiology sections. So now let's touch on the tumors that can occur in the salivary glands. Usually, these are benign tumors, and most are in the parotid gland. First, pleomorphic adenoma is the most common, and it is benign. These present as a painless, movable mass, and they are associated with high recurrence. Second, Warthin tumor is another benign growth. A Warthin tumor is actually salivary gland tissue growing in a lymph node. What kind of growth is this? It's also known as a heterotopic growth. The last tumor we'll mention is the mucoepidermoid carcinoma. This type of cancer has 3 cell types: squamous, intermediate, and mucus-producing. The mucoepidermoid carcinoma is the most malignant salivary gland tumor. In this image here, you can see mucus production toward the center of the glands. Also note that it is not encapsulated. Let's move on to the esophagus and achalasia. We mentioned this briefly before in the context of nitric oxide and a lack of NO being implicated in some cases of achalasia. So let's look now in more detail at this disease. Achalasia is defined as a failure of relaxation of the lower esophageal sphincter, or LES, due to the loss of the myenteric plexus. What happens if you lose the myenteric plexus? Because the LES cannot relax, food does not pass from the esophagus to the stomach in its usual coordinated manner, and this gives the patient dysphagia to solids and liquids. What would happen if there was only an obstruction? Well, with just an obstruction, there would be no dysphagia to liquids. So this helps separate an obstruction versus achalasia, where achalasia has dysphagia to both solids and liquids. To diagnose this condition, you would want to do a barium swallow test that demonstrates a bird's beak appearance, which you can see here. This condition is associated with a heightened risk of esophageal squamous cell carcinoma. Interestingly, achalasia can rarely be caused by Chagas disease. This is frequently tested on the boards. Remembering back to microbiology, which bug causes Chagas disease? That's right, it's Trypanosoma cruzi. You should think about this as an answer choice if the patient is a South American immigrant. You can also see achalasia-type pathology in Crest syndrome. Next, let's talk about some of the more common esophageal pathologies. First, gastroesophageal reflux disease, or GERD, is commonly known as what? That's right, heartburn, which can induce regurgitation upon lying down. If a patient presents with nocturnal cough, dyspnea, or adult-onset asthma, GERD should definitely be a consideration on the differential. GERD can be caused by a decrease in lower esophageal sphincter tone, which thereby allows the contents of the stomach to reflux into the esophagus. Another important esophageal pathology to know is esophageal varices. Esophageal varices we mentioned before in the context of portosystemic anastomoses. This is painless bleeding of the submucosal veins in the lower 1/3 of the esophagus and is a common source of upper GI bleed in patients with liver disease. It's important to remember that this bleeding occurs in the lower 1/3 esophagus. Finally, esophagitis is a general term for conditions associated with reflux, herpes, CMV, candida, or toxin ingestion. These things are important to remember in terms of esophagitis. Mallory-Weiss and Boerhaave syndromes are both caused by vomiting, and the exam will usually list both in the answer, so you need to be able to differentiate the two. How are they different? Well, Mallory-Weiss is a tear at the GE junction from severe vomiting, which usually occurs in alcoholics and bulimics. Boerhaave syndrome is actually a transmural rupture. This transmural rupture of the esophagus from violent retching is a surgical emergency because bacteria can invade from the mediastinum and cause devastating infections. In Boerhaave's, the patient may have some element of hematemesis as well, but the main symptom here, as in with any perforation of a hollow viscus, is pain, typically in the chest. A chest X-ray will show pleural effusions, and physical exam will reveal crepitus on the chest wall or subcutaneous emphysema. Esophageal strictures are a long-term consequence of lye ingestion or acid reflux. This will be a commonly tested association. Eosinophilic esophagitis, on the other hand, is an allergic inflammatory response, as one would suspect from the name. Eosinophils are in the esophagus, and food allergens cause dysphagia, heartburn, and strictures. Here you can see the eosinophils localizing into the esophagus. Sclerodermal esophageal dysmotility is part of what syndrome? That's right, it's part of Crest syndrome. Sclerodermal esophageal dysmotility is a progressive motility dysphagia in which there is smooth muscle atrophy. A decrease in the lower esophageal sphincter pressure and dysmotility causes acid reflux and dysphagia. Lastly, Plummer-Vison syndrome is an important triad of features. This will typically present on the boards as dysphagia, iron deficiency anemia, and glossitis. Glossitis is inflammation of the tongue, which causes it to be swollen and change color, which results in the surface of the tongue appearing smooth. The dysphagia in this case occurs secondary to esophageal webs. This can be hard to remember, so I use the mnemonic, the Plummer-Vison digs a hole for the iron pipe. D stands for dysphagia. This dysphagia is coming from the esophageal webs. I is the iron deficiency anemia. G is for glossitis. And S is for the increased risk of squamous cell carcinoma. You treat this with iron supplements. Barrett esophagus deserves its own separate mention because it is such a highly tested topic. This is a classic case of metaplasia. What is metaplasia? Metaplasia occurs when one cell type changes to another in response to its environment. In Barrett esophagus, the non-keratinized stratified squamous epithelium of the esophagus is exposed to acid due to GERD, and it undergoes metaplasia from non-keratinized squamous epithelium into intestinal epithelium with non-ciliated columnar cells with goblet cells in order to defend itself from the chronic acid load, which you can see here. This is associated with esophagitis and ulcers and an increased risk of esophageal adenocarcinoma. Here again, you can see this border differential between the normal epithelium and the exposed epithelium, which has undergone metaplasia. Okay, time for a flash quiz. An alcoholic is brought into the ED vomiting copious amounts of blood. The condition this patient likely has causes painless bleeding from which vessels? This is a great review question to bring back our anatomy. Important things to note are that it's painless bleeding and it's in an alcoholic. This means that in an alcoholic, they are likely to have varices in the esophagus. Thus, it is the submucosal veins in the lower one-third of the esophagus that form varices that are causing this painless bleeding.